Yeah, am I
Unmute
audible now?
yourself.
Am I?
Now, yeah,
Yeah.
yeah, we can hear you now.
Yeah, good morning, everyone. Thank you, IAPM, particularly Dr. Ashranti Karmam, who has given me this privilege of being part of this meeting. It's my pleasure and privilege to introduce today's speaker. Before that, let me introduce myself. I am Dr. Sudha Murthy. I'm the Director, Clinical Support at Datar Cancer Genetics. I'm an oncopathologist and I was there at Vasabatarakam Indo-American Cancer Hospital for the last 20 years before I moved to Datar Cancer Genetics. So with this brief about myself, it's my privilege to introduce my colleague, Dr. Vishal Rao, with whom I have had the privilege of working for 8 long years at Indo-American Cancer Institute. Dr. Vishal Rao is a very passionate oncopathologist who has done his MBBS and MD from Mahatma Gandhi Institute of Medical Sciences from Wardha. He thereafter has been pursuing his passion in GU pathology. He did his postdoctoral fellowship at in oncopathology at Tata Medical Center, Kolkata. He also did his observership as postdoctoral fellow in Johns Hopkins Hospital under the able guidance of Dr. Epstein. Dr. Vishal has a post-MD experience of over 12 years and his fields of interest are genitourinary oncopathology, and we can see his passion when he speaks. He also is interested in GI and gynae oncopathology. He is presently working as the senior consultant pathologist at Vasabatarakam Indo-American Cancer Hospital in Hyderabad from 2014. Can I have the next slide, please? Dr. Vishal has gold medals, awards, and honors to his credit. He's been the US USCAP ambassador from January 2016 to 2017, and he's the joint secretary of SGUP, that is the Society for Genitourinary Pathologists in India, and he has been recently awarded fellowship as visiting scientist as IARC editor for the WHO Blue Book on Urinary Systems and male genital organs. Dr. Vishal also has the credit of starting the first PDCC course in uro-oncopathology in India under the aegis of Indian College of Pathologists recently, and they have enrolled 2 students. He has over 25 international and national publications in international and national journals. He is a reviewer for Indian journals, prestigious Indian journals, and has been a guide and co-guide for postgraduates and who have contributed to these publications in GU pathology. Over to you, Dr. Vishal, without further ado. Thank you.
Thank you, ma'am. Hope everybody can hear me clearly.
Yes, yes.
Yes.
Okay. Thank you. With this, thank you, ma'am, for the kind introduction. So I'll directly move to the topic of today's discussion is grossing to reporting of urinary bladder. Basically, I will go along these lines like anatomy, histology, histopathology, then how we'll do the grossing and reporting of the small biopsies and TURBT specimens, the radical specimens. What are the daily nuances which we faced during bladder reporting, and what are the histological subtypes and variants, the ISC overview, and the molecular to leave you to the molecular overview. So anatomy, as students are there, you know that it's a hollow organ and which has the main diffuser body, the muscle, the superficial trigone, the deep trigone, the area between the ureter and urethral orifice, the bladder neck, and the urethral smooth muscles and striated muscles. Histology, it comprises of the epithelium, and epithelium have the basal cells. The basal cells, the intermediate cells, and the umbrella cells, and the muscularis propria and the adventitia. So when we see the normal histology of the urinary bladder, it's a vertical polarity is maintained, and there's a uniform cells with 3 to 5 layers thick and consist of the basal layer, the intermediate layer, and the umbrella cells. So in a hyperplasia, there is nothing but there is an increase in cellularity of these layers. Dysplasia, however, will have the polarity will be lost, and there will be atypia in the epithelial cells. Carcinoma in situ, which is very important to report in a bladder tumors, will have gross loss in polarity. Marked atypia will be there, and you can see high hyperchromatic nuclei, moderate amount of cytoplasm, and prominent nuclei will be there. Now coming to the our normal histology towards the benign histology, the most common histology which we face is the cystitis cystica or cystitis glandularis, which is these nests, the von Brunn nest, which acquire the luminal spaces and they become cystically dilated and undergo glandular metaplasia or intestinal metaplasia, which is uh, one of the important yeah important metaplasia. It is not moving. Okay. Other very rare, not very common, but still recently we got a case, and this is papillomas, urothelial papillomas, where you will see an exophytic growth with slender papillary structures with minimal branches, and the lining is benign only, normal thickness with, as you can see in this, umbrella cells are there, and this is an exophytic growth, and the thin slender papillae are there. Inverted papilloma, which was added a few years back, and this it is an, as compared to the papilloma, it is inverted papilloma will be opposite, like it will be endophytic growth, and it has a thin anastomosing uniform trabecular with peripheral palisading, as you can see in this. One of the most controversial, not most, but nowadays it is being studied a lot. The panlum, the papillary urothelial neoplasm flow malignant potential. The papillary cores, as you can see, are lined by urothelial cells, and there is no atypia. As you can see, polarity is not lost, and atypia is not there, and it is in a papillary pattern, and these are lined by normal urothelial cells. However, when you compared with a low-grade non-invasive papillary urothelial carcinoma, as you can see, there is a loss of polarity is there, mild to moderate atypia is there, occasional mitosis can be seen in low-grade tumors. In high-grade tumors, there is definitely loss of polarity will be there. This atypia will be moderate to severe, and mitosis will be more frequent, and they will be found on the surface as well. So this is an invasive urothelial carcinoma where it is invading the muscle bundles. You can see there's a thick muscle bundle which the tumor is invading. This is a high power view of the same tumor where you can see marked atypia is there, and there is hyperchromasia, prominent nuclei is there, and occasional mitosis are also there. So this is the overview of histology and histopathology, which the lesions which we see in bladder. Now we'll come to the grossing of the bladder tumors. First, before grossing, I always tell my students that before grossing, first I try to acquire what are the details, clinical details, and what are the radiological details, what is the type of tumor, whether it's a papillary, non-papillary, ulceroproliferative, what type of it is there, and what is there any prior diagnosis, because this is a recurrence, there is a recurrence of this disease, many a times recurrence occurs. And is there any prior treatment, or like in non-invasive low-grade patient will receive BCG treatment, and in high-grade they may receive chemotherapy or radiotherapy accordingly. So, and then that will hamper the histology, because if patient has received radiotherapy, then there will be changes of radiotherapy. If patient has received BCG, there may be granular formation. So that is why we have to always acquire the relevant clinical and clinical history before going to any grossing of the specimen. So what are the specimen which we received in our lab is small biopsy, TURBT, radical, partial, very rarely wherever there is a urachal cyst or a urachal tumor, or when the bladder is infiltrated by a colonic tumor. So then only we will get partial cystectomy. But for primary tumor, we'll mostly will get cystectomy or cystoprostectomy. So first, we'll see the TURBT, how to go about it. So small biopsies has to be processed as entirely you process any small biopsy. Kindly give the entire specimen. TURBT, again you can weigh the fragments, see the larger fragments, and you can see the fragments where you suspect that the areas are gray, white, or any suspicious area. Try to submit entire, but again, according to your institutional protocol, don't try to give 10 to 15 sections. You can give 4 to 5 sections, and then you can see, assess if the tumor is there, then it is okay. If it is not there, then you can go for more specimen. So this is how we receive in our the requisition in our lab. The clinical history, short clinical history is given. The specimen, what is it? It's a urinary bladder, TURBT biopsy, superficial bits, and the deep tumor bits. So you record all these findings, and then microscopic findings you have to write, and what type of tumor it is. Then you have to write whether it is in. So uh, always write the entire when you're writing the impression, you write the urinary bladder TURBT biopsy, whether it is superficial or deep. Then you have to write whether it is invasive, non-invasive, then papillary, non-papillary, urothelial carcinoma. Grade is very important, high grade and low grade. And then where it invades, whether it is invading the muscularis propria or it is invading the lamina propria, and LVI is seen or not. Muscularis propria is identified in sphere of tumor. So because muscularis propria is very important part of the biopsy, because it denotes the completeness of the procedure. If muscularis propria is not removed or not found in the biopsies, then it is like they have removed only superficial tumor, part of the tumor. So you have to mention whether the muscle is present or not, or if present, it is free or not. Similarly, in the non-invasive also, same you have to do. Now coming to the radical specimens. So radical specimen, before going to any radical specimen, I always tell my trainees that you have to know the staging of the tumor, because if you know the stage of the tumor, then only you can do a proper processing, because what sections I have to do, because no matter how many sections if you give, but only the sections which are pertaining to the stage, only those are important. So as you can see, grossing plays a very important role in cystectomy assessment. It upstages the tumor. If you see a gross tumor, it will upstage the tumor immediately to 3B. And that is why, and the muscle invasion also, superficial and outer half also. So that is why for all the cases, you need to know the staging of the tumor. So how to proceed? So record the outer dimension of the bladder, length, diameter, and attached ureters. In the entire specimen, open. I think you can open it. You can put a probe in the urethra, and you can just give a straight cut and then open it like a Y incision. I will show you the images also. And pin it and fix it overnight, or fill with formalin. You can put a cotton ball and put it inside the bladder, and then it can be inflated with formalin through the urethra and allowed to fix and expand. So when you receive the specimen in your department, try to ink it the peritoneal surface and the anterior and posterior surface. Then, as I told you, you can put a probe here, and you can just cut it straight and then open like a V. This is the dome of the bladder, the anterior, posterior, right lateral, and left lateral of the. This is the prostate. So after fixation and opening, you may find a growth. Uh, open it. It is properly fixed, and then this was an ulcerated lesion. And now this, when you open the bladder, as you can see, there is a growth inside. You mention the growth, where it is located, whether it is at the dome anterior, which wall it is there, or in the trigon, or it is entering into the prostate. And see, we have to you can ink whenever we get a prostate along with the bladder, we usually ink it and take a cross section so that we can take most of the prostate sample, most of the prostate. Many of our cases we have found incidental. Now we are finding incidental prostate carcinomas in bladder, which are separate from the main bladder tumor. Also, in cases of female, you may the uterus may be unaccompanied. Here, it is a tumor in the vaginal wall actually, and the tumor was infiltrating into the bladder. So the bladder and the uterus and the vaginal wall was taken out in this case. So as I was telling you about the staging, just say this tumor has come out and it is in the ureter. So this becomes a T3B. The stage is it is now T3B. So what you do is you take 3 to 4 sections from the bladder, ideally 1 centimeter from 1 centimeter, one section from each centimeter, and from if you see any variegated areas. And after 3 to 4 sections from non-necrotic areas, try to sample the entire wall, like the dome anterior wall, right, both the lateral walls, trigon, and the prostate, and the seminal vesicles and ureter. Ureter are usually in our setting in our hospital, they are sent separately also. So this is the key to section. Tumor 3 to 4 non-necrotic area, sections from all the walls, prostate biopsies, bilateral seminal vesicles, other organs if seen like cervix, rectum, which are accompanied with the main specimen, urethral cut margin, you can take a shave margin, and ureter cut margin. So what are the important aspects of diagnosis and reporting? So tumor classification is important because whether it is a urothelial or there is a differentiation, squamous and glandular differentiation, I will discuss in subsequent slides. The growth pattern, whether it is papillary or non-papillary. The histological grade, whether it is low grade and high grade, and the stage, what is depth of invasion, and finding of CIS, sorry. Carcinoma in situ is very important because it will warrant the patient to have radiotherapy and vascular invasion. So this is how we receive in our hospital the clinical diagnosis, short history. Then the specimen we received is urinary bladder radical cystoprostectomy, the bilateral pelvic lymph nodes, and the ureteral distal margins. So this is how we record our finding for and the size of the tumor, the location, and the extension also. So this is how the final report looks like. So as I told you that you have to write the organ, the procedure which has been done. If laterality is required, here not required, but wherever laterality is required, kindly mention the laterality also. Then invasive urothelial carcinoma, then all the points which are very important because this report will go to a medical oncologist, radiation oncologist, and surgical oncologist. Surgical oncologist will be looking for the margins and the size, tumor location, and the size of the tumor. And the site of the tumor, size of the tumor, what is extension of the tumor. Again, in prostatic stroma, if it is prostatic invading directly the prostatic stroma, then it becomes 4A, but along the urethral it is still 2, stage 2. So again you have to see how the invasion is occurring. LVI, PNI is not included in CAP. So I report according to CAP. So PNI is still not included in CAP, but wherever you are seeing, I think we should mention it. And whatever, right, whether the margin is involved or not, what about the rest of the walls of the bladder and the seminal vesicle? So you can see two and the lymph node. So lymph node, whenever lymph node is positive, you have to mention how many lymph nodes were found positive out of how many lymph nodes, and the extranodal extension is there or not, and what is the size of the tumor deposit rather than the size of the lymph node is important. And again, whichever specimen is, whether it is positive or negative. And final, you have to give a pathological stage. I think this is the most important slide, and you should all follow a particular mode of writing the report, which will help you to give maximum information to all the clinicians. So now we have seen how we have seen the normal histology, histopathology, and how to report. But what are the problems we are facing? These questions which are asked by many of my fellow colleagues and my students. So first question is, sir, what is the how to identify muscularis mucosae and muscularis propria? Definitely, muscularis mucosae, they are haphazardly arranged muscle fibers, and there will be prominent blood vessels mark the level of mucosae. However, the muscularis propria will be thick muscle bundles. And yes, this picture I kept you to just imprint in your mind that see the difference between the mucosae, the thin fibers and the thick fibers. Okay. Low grade urothelial carcinomas, again, there is a, the, for all the invasive urothelial carcinoma, they say that it's a high grade. But sometimes I have seen occasional cases where the morphology looks like very low grade and it is invasive. So these are the non-invasive papillary urothelial carcinoma, low grade. You will see there is loss of polarity, moderate, mild to moderate atypia is there, and mitosis here you can identify one mitosis. Mitosis, occasional mitosis will be there, and they won't go to the surface. This is invasive urothelial carcinoma, high grade. Again, you can see thick muscle bundles are there; they are invading it, and pleomorphism is high. So second problem which commonly everybody faces, how to differentiate low grade and high grade. So low grade, as I showed you, there will be definitely loss of polarity. There will be mild to moderate atypia, and conspicuous nucleoli will be there, and occasional mitosis will be there, usually limited to the base or the mid part of the epithelium, not to the surface. Okay. However, high grade tumors will be high grade tumors, whether invasive or non-invasive, again will show features of loss of polarity. There will be moderate to marked atypia, as you can see in the slide, and there will be prominent eosinophilic nucleoli. Brisk mitosis will be there, and that can be seen on the surface as well. So this is a simple algorithm. So this is a simple algorithm which was published in 2004, where if you have moderate to severe nuclear grade, if it is yes, then it's a high grade. If it is no, then if you see for the polarity, if the polarity is lost, then it's a low grade urothelial carcinoma. If polarity is not lost, then it is a pulmonary. So I think this is a very simple and straightforward algorithm which I also use in my day-to-day practice, which helps me to differentiate between a column low grade versus a high grade. Yeah. So now coming to the third problem. Third problem is that what the pathology says and what the clinician says are totally different things. When we say non-invasive, it means non-invasive. It doesn't mean it doesn't interfere with the lamina propria, doesn't go musculus propria. But for the clinician, when they say in non-invasive, they mean non-muscle invasive. They include this superficial non-invasive and lamina propria in situ, everything in non-invasive. And for us, the non-invasive means no invasion at all. But for them, lamina propria also they don't consider. So many a times, my clinician also they say when I write non-invasive urothelial carcinoma, they ask me, Dr. Vishal, what about the lamina propria? I said when I have told non-invasive, then it is lamina propria is free. But they say that you write that lamina propria is also free. So there is a discrepancy between. I have raised this point. We have to look into future what we can do about this. And the main debate of why this invasive and non-invasive or superficial tumors have to be differentiated is that these non-invasive tumors they reoccur, they can undergo conservative management, they have a very good prognosis, and the grade and they reflects the instability of the tumor. But in the other hand, the invasive tumor are more aggressive. They tend to metastasize, and more radical treatment where radiotherapy, chemotherapy has to be given, and poor prognosis is there. And staging is the most important thing in this. So why we are breaking our head on this pulmonum and this low grade, high grade, and like why the stratification? So for this question also, the 2004 the WHO and ISAP came up with the criteria of how these terminology affect it, because they tend to recur. They have their own percentage accuracy, as you can see. They have a grade progression also, where papilloma is there at the lowest end and low grade is the highest. And then there is a stage progression also, which is highest in high grade. And prognosis wise also, as you can see, 100% in papilloma and high grade is 65 to 90%. So So the main intent of this stratification is to categorize these patients into low risk, intermediate risk, and high risk. As you can see, these are the NCCN guidelines. As a pathologist, I tell you, not we are not just diagnostic. Now we are part of the MDT team, so we have to be upbeat with them, and we have to be know what are the guidelines also that will help us to report better and the points which are included in the risk stratification and treatment protocols. So, like in low grade, the palm is there, low grade TA tumors less than 3 centimeters. See, the grade and stage is there. And then intermediate grade risk is there, in which there are low grade tumors more than 3. So that is why gross findings are important. See, multifocality has been included. So it is unifocal, multifocal, those things have to increase. And again, as I told you, clinical history is also important for risk stratification, like BCC unresponsive cases and LVI and prostatic urethral invasion is included in high risk. So this is another peculiarity about of this tumor is when do we call it cancer? For other organs, directly we call cancer for the uh, invasive tumors, but here you start calling it from low grade. So that is one of the problems. Second, what was the significant changes from 1973 to 2004? Was papilloma was unchanged, but grade 1 was then change into low grade and palm, and grade 2 and grade 3 was unchanged. So the main changes which occurred in the grade 1 and grade 2 tumors, these are the problems which we face. Usually we face during during our day-to-day reporting also. Sometimes because focal areas are looking high grade, most of the it is looking low grade. So I think in the future maybe we'll have a 5-tier system which will be more it will be good for pathologists, but again now I don't know how the clinician will take it, but we have to look into this classification to simplify it more. So as you can see the history of bladder tumors, how the lesions have been added from papillary lesion, invasive lesion, flat lesions later, and then the recent inverted lesions were added to the list, and the list is ever growing. And this is the 2020-22, the fifth edition, which came in to which I also received my copy last week. So this is these are the tumors which are included in the list of urothelial carcinomas. And I think this time the list has been simplified rather than being more complex, and which is better. So so now what are the subtypes of the urothelial carcinomas? So if you see that the subtypes of the urothelial carcinoma and those with divergent differentiation they're all considered high grade tumors. So usually the clinician asks what is the grade of the tumor. So you have to tell that they are all considered high grade. So urothelial carcinomas have been divided into the urothelial divergent differentiation and subsets. So divergent, which we see is very commonly squamous differentiation, and the second common is glandular differentiation, tropoplastic differentiation, urothelial carcinoma with Mullerian differentiation. So another important point which has been raised in this WHO fifth edition is the variants. The variants is now very interchangeably used with subset and variants, and we are not sure what is what is what. So variants is most commonly used to denote the genomic alteration. So that terminology is now used only for those cases only where there is genomic alteration, and subset will be the whatever they are just a morphological differentiation. So these are the subset of urothelial carcinoma which has been described in the new WHO. So though they are rare, but if you know, do you keep the list with you? Then if you know it, your brain knows, then it will see those lesions also. So try to keep this list with you. So it will help you to find these tumors. Squamous differentiation, as I told you, is the most common differentiation, and it is very important also because it is associated with worst cancer specific survival, and also it will warrant the patient for a radiotherapy or a more aggressive therapy. Uh, try to sit with your clinician sometime, because you will find more important points there. So the commerce differentiation, we tend not to search for it. Definitely kindly scan the entire slide for any commerce differentiation, because it's a very important point for the assessment of the patient treatment and risk stratification. Glandular differentiation also, but it does not influence the prognosis. However, it is present at an advanced stage. So definitely you should be mentioning this. Circumrite differentiation, not much common, but we have seen one case where we had sarcomatoid differentiation and neuroendocrine differentiation, which was were quite evident. And whenever you see sarcomatoid differentiation, it is most of the time it is mixed with urothelial, neuroendocrine, and squamous and adenocarcinoma. So it will be mixed with other components, and it can show differentiation from simple spindle cell pattern to pleomorphic sarcoma, including osteosarcoma, chondrosarcoma, and different types of sarcoma. And presence of one or more heterogeneous components is suggestive of adverse behavior and associated with poor survival. This is the case I was talking about, the neuroendocrine. This is the neuroendocrine counterpart. That was the sarcomatoid counterpart, the same tumor, where we saw this high-grade morphology, and we went for neuroendocrine marker, and a very high Ki index was there. So this the percentage of neuroendocrine in this tumor was 30 to 40%. This was a very rare case, actually, tumor with micropapillary pattern, which uh, you can find. And usually these tumor, up to 25% of these tumor are HER2/neu positive. We tried HER2/neu, but the HER2/neu was not positive in this case. However, if positive, patient may get a treatment, HER2, anti-HER2 treatment will be there. So keep in mind these various subtypes. Recently we got this metastatic serous carcinoma. It's a known case, so that is why earlier we didn't have the history, and we were thinking some high grade papillary, right? But it was looking very high grade, because as you can see that prominent nuclei nailing. So we had a doubt, is it real a high grade urothelial carcinoma? Then we went back and saw the history, and this patient has a serous carcinoma, and this was a metastatic serous carcinoma, which was confirmed by ISC. So after diagnosis, going through the nuances, going through the subtypes, now I'll talk about ISC overview. So ISC, always you have to interpret in correlation with clinical findings and radiological findings and the morphological finding. Always morphology is the gold standard. You always remember that ISC is not the solution. It is only supportive. It is never the primary diagnostic thing for you. Morphology is only the gold standard. And whatever question you will ask, that if you ask the correct question, then only you will get the correct answer. If you throw ISCs without seeing the morphology, then it won't solve the purpose. So always you have to never use it in isolation. I have always in correlation with the macroscopic and microscopic findings. And do not use a single marker in isolation. Always use a panel of ISCs, and it should be used in the knowledge of the sensitivity and specificity. Like very commonly, CK7 and 20 are used, but do you know the sensitivity and specificity of these tumors? Very less. It is less than 50%, 75%, like that. They are not 100%. And morphology is primary importance in diagnosis. So that is why I'm telling you that use very wisely. So this is one of our case, as I showed you the gross before, that this is a vaginal tumor, which was negative for GATA and P63, but it was very beautifully positive for P16, as you can see the nuclear positivity of P16. Another case where the bladder tumor went into the rectum. So as you can see, CK7 and CK20 is and CDX2. All three are negative, and GATA is very nicely nuclear positive. So what are the recommendations by the ICEP? The ICEP recommends GATA3, CK20, P63, and high molecular weight cytokeratin, CK5/6 for the initial panel, where you have a poorly differentiated morphology. we have done a study. One of my student has done a thesis which has been published in Indian Journal of Surgical Oncology last year in April 2021, and where we have studied the GATA expression in all different grades and variants, and we have seen that the positivity of GATA is increasing high as the tumor is the grade is increasing, and in metastasis also it has helped us. And so as you can see, we have used a panel of CK7, 20, P63, MCR, and CDX2 and P16. And this panel has been included in keeping in view of the metastasis from prostate, colon, and cervix. So coming to the last part of the talk is the molecular way. What is so at the end of the day, now everybody is talking about molecular. So molecular is the way to go to the future, definitely. And this is the flowchart. As you can see, the studies have been started as 2003, and many scientists have come up with the pathologist has come up with these classifications. And as you can see, the new WHO has endorsed this molecular classification of muscle invasive tumors, and which they have classified into six independent muscle invasive systems: the luminal papillary, and luminal non-specified, luminal unstable, stroma-rich, basal squamous, and neuroendocrine-like. So, and the neuroendocrine like basosquamous and the luminal unstable are the associated with worse prognosis overall. And one of the clinicians, uh, one of the clinician asked, "Is this the same luminal vesicle classification as the breast one which we have, luminal A, luminal B?" But no, I think it is different because here the luminal cells are the most of the superficial cells, and the basal cells are the basal cells which line the urothelial. So these are the unstable one. These are the worst overall prognosis. So there are a plethora of novel prognostic and predictive biomarkers are rapidly emerging with long this RNAs, microRNAs, epigenetic changes, and different proteomic signatures, and variety of tumor immune microenvironment markers are also there. And many of these markers are also being investigated in blood and urine samples, and assessing circulating proteins, RNA, and cell-free DNA in patients with bladder cancers. So definitely there is a long way to go since the molecular classification uh, has been there in the WHO now. So I think more and more studies will come up and to validate these various molecular subtypes, which will ultimately help in the treatment of the patients. So, so summary. So what are the points to remember? So again, as I told you, clinical details are required before going into the reporting and grossing and reporting of the samples. Prior treatment should be find out because if it is a radiotherapy is given, that there may be radiotherapy related changes may be there, and which may mimic a poorly differentiated urothelial carcinoma. So I think that is important. And what is the location and the size of the tumor? Extent of the tumor is important for staging, as you have seen, uh, for proper risk stratification and treatment protocols to follow different treatment protocols. Present and extent of adjacent carcinoma in situ is very important. So always look into the adjacent epithelium, how it is, because again, patient will require adjuvant radiotherapy. Lymphovascular invasion. If it is present in a TURBT specimen, people will they may go for the lymph node dissection also because there is a chance of metastasis in the lymph nodes. So these are the points which you have to take into account before reporting and grossing of the your bladder specimens. So I don't think so. We have dysmorphed the urothelial morphology. I thank you. So I thank you. I thank um, IAPM for giving me this opportunity, Dr. Kim Vajpayee Madam, Dr. Aswantikar Madam, and I thank my department, my HOD, Dr. Sushila, and Dr. Professor Sundaram, my student, Dr. Shriya, and Dr. Devachmita, and all my colleagues, and Dr. Sudha Murthy Madam for moderating the session. I'll be happy to take any. Thank you.
Thank you, Dr. Vishal. Ma'am, you would. Dr. Ashranti, you're speaking.
Oh, yes, no. Dr. Sudha, we'll take the questions. Can you see in the chat box what are the questions?
Sure. Yeah, thank you, Dr. Vishal, for that exhaustive
No, that,
presentation.
yes, yeah.
Yeah,
Excellent, sir.
excellent presentation. Just for the summing up, we are talking about on the clinical perspective, whether it is non-muscle invasive or muscle invasive. And as Dr. Vishal rightly pointed out, these are the questions that students need to know. When we are
Yes.
saying it is T0 or T1, it is non-muscle invasive, and the rest of the stages fall under the muscle invasive bladder cancer, because the treatment is now tailored into these two categories apart from the morphology. Now, I would like to, there are several questions and comments here. Dr. Vishal, if you can please take up, or anyone in your group. So from Dr. Bharat Rekhi, we have this question. What is your perspective on the role of urine cytology, including the Paris system, in the current management of bladder cancers?
Dr. Vishal.
Yeah, ma'am. I'm just seeing the question. Sorry.
Yes,
I'm
yes.
not
You
able
see,
to see the chat actually.
It's in the chat box. He also has one more question. Does a certain percentage of neuroendocrine component versus small cell / neuroendocrine carcinoma, meaning large cell also would be included, large cell neuroendocrine, influence further management strategies at your center? These are the two questions from Dr. Bharat Rekhi.
Yes, sir. Cytology, I don't do that actually, sir, but definitely cytology plays a role. Like Paris system, I think category 3, if it is there, um, it warrants a Eurovision fish study. So again, yes, cytology is an important part, and again, correlating with the morphology and radiological finding, the surgeon takes the call. For a non-invasive tumors, definitely they will do a TURBT, which is the protocol here in our institute. Again, muscle invasive tumors will go under radical cystectomy. And if there is a like this tumor which I showed you, where there is a, in my case, the second question, in my case, we found 30 to 40% of neuroendocrine differentiation, and it was very high grade. Definitely, that will drive the treatment in this case, rather than the routine urothelial carcinoma.
please see the other questions, Dr. Vishal.
Yes.
How to do grossing of prostate in case of cystoprostatectomy? So very
Yeah.
good question. In cases of what I do, as I told you, that I take a oblique sections of both the lobe, right and left lobe, which will cover most of the part of the prostate. And we have found like 3 to 4 cases incidental prostate carcinoma also in that, where atypical glands are there. So what we do is, first we confirm it by ISC. We do an AMCAR and P63 in high molecular weight keratin. And so after that, when it is confirmed, we try to slice the entire prostate and try to give with the margin. As much you can give with the margins. We are trying to ink it. Anyhow, we have inked it before only. So margin is not a problem. Then we give serial sections and we submit the entire prostate. Do not do unnecessarily, do not submit the entire prostate. Only when there is a tumor, then only you give for proper assessment of the tumor of the prostate.
One question is there on piece of urine cytology. Can you see that piece in urine cytology?
Ma'am, can you see? I am not able to see. I'm Murthy.
Yeah, no, please answer that question. He has written, I think. Let me check. Yes.
Dr. Bharat Rekhi's question, I think
That I have answered actually.
he has answered.
Yes. Is
Yeah,
there?
fish in. Eurovision utility fish in urine cytology, yeah, from Dr.
It's
Gopal.
for urine
Yeah,
cytology.
yeah, limited. My knowledge is limited because Madam can.
Yeah. If I may take that up,
Yeah, yes.
yes, Eurovision initially, when it started off about 5-6 years ago, there was a lot of hullabaloo about it. But now with the advent of NGS, it gives multiple parameters in one go, and with the role of FGFR3 mutation and fusions becoming very important. The role of now Eurovision is getting. When it started off about 5-6 years ago, there was a lot of hullabaloo about it. But now with the advent of NGS, it gives multiple parameters in one go. And with the role of FGFR3 mutation and fusions become.
Yeah. Madam, you can
Sorry,
talk.
I'm sorry, it
Sorry.
just went on.
Yeah.
Yeah. So that has become limited. And Dr. Vishal, I had this question related to this. Do you have any advice to the postgraduates here how to fix the tissue? Because now we know FGFR fusions are so important, mutations are so important, and RNA sequencing becomes a challenge if tissue is not properly fixed. So any advice on that? Because pre-analytics are the most important component of molecular analysis.
Yes. I always tell my trainees that fixation and grossing are the most important station for any reporting. Now we have gone till molecular. So I think fixation plays a very important role, and always try to use fresh formalin, and always make sure that you chosen the right whenever I see a very small container, I just replace it with a long, because from the OT it may come in a long small container. Try to change the container where you can put 1:10 ratio formalin, fresh formalin. After before that, properly, if you are experienced enough, try to cut it, open the specimen in a Y shaped as I showed you, and then you can put a cotton inside, and you can make a cut inside the through and through cut inside the cut inside the through the tumor also, so that the tumor also fixes. And again, you can put a cotton, and then you can just put it in a jar which is appropriate, more than 10 times the specimen, and maybe in a big jar, and appropriate, and whatever formalin has been sent from the OT, change the formalin, put it in a fresh formalin after cutting and putting the cotton.
Can I just ask you one question, Dr.
Yes,
Vishal?
Yes, ma'am. Yes, ma'am.
You were talking about the prostate, right?
Yes.
Along with the bladder.
Yeah.
So will you tell the residents what to do with the prostatic urethra? Do you need to pay some more attention to that, or you don't really need to pay any attention to that?
No. It is important. Prostatic urethra is important, because the urethral cut margin also we are taking. We are taking a shave section for that assessment of that margin also. And while cutting, also try to take from the prostatic if the tumor is infiltrating, because it will upstage the tumor. If the tumor is directly invading the stroma, it will be T4. But if it is going to along the prostatic urethra, it will not upstage the tumor. So it is very important to sample prostatic urethra also.
Yeah. Another thing about the microRNAs, nowadays we all tend to work with microRNAs, many of us.
Yeah.
And I think my one PhD student just completed, he submitted yesterday only his PhD thesis. And so the best definitely is to take a fresh tissue. Otherwise, also we were using the archival tissue for the microRNAs. So I think we were quite successful.
Yeah.
Yeah, so I think proper fixation definitely is, I think, the key point or the key issue for that.
Thank you.
Professor Siddhartha, speak something. Professor Siddhartha.
Dr. Asranthi, one point.
Yes, sir. Yes, sir.
During fixation, what people forget is they prepare the formalin, but it should be properly buffered. Actually, what happens is sometimes they add sodium acetate or something and just prepare like that. If it is properly buffered, only then especially for molecular biology studies, it's better. So that's something many people don't do. They make 10% just like that and keep it. So that will not be sufficient. I just wanted to add.
Yes, sir. So we have Professor G.N. Mahanti. G.N. Mahanti also. Professor G.N. Mahanti wants to tell.
Gotcha.
Professor Ji.
Uh, I have a very emotional attachment with Dr. Rao. So in that case, I'm just telling, in 2008, I took a seminar, slide seminar, IATN, so 2008. And to get that seminar, I did 2 years earlier. I tried to get it. So when I became president, I had the occasion to giving a ICOT memorial lecture where I just, that is the lecture was the relevance of classification of urethral tumors. And that with me, it was 1973 classification and 2004 classification. I made a comparison of two, and all cases of my 1973 classifications, all cases, again I reclassified in 2004 and compare. One thing I found that punlam, everybody, all clinicians, surgeons ask, what is this punlam? I find there are a lot of overlapping of papilloma, inverted papilloma, and punlam. So that is a thing I found. And next is some punlam as a low-grade carcinoma. So all these things, now I am very happy to see almost Dr. Rao covered everything, almost everything. And my knowledge limited to 2004 classification. The rest of the thing I learned from him. And Dr. Rao, very aggressive man. He made me a member of the Society for Urogenital Pathology. I am one of the member of the urogenital pathology, and everything he asks, sir, you aren't somebody, you just influence, ask somebody to become our member. So we are about 100 people are member, and everybody should become member and learn urogenital pathology from our society. Thank you very much, Dr. Rao and Dr. Aswanti, giving me the opportunity to just share my knowledge.
Thank you so much. And we have some questions, rather statements from Dr. Pranab Bhattacharya. Dr. Rao, he has told that plasma-cyted carcinoma one thing, and second is it's difficult to differentiate sarcomatid carcinoma and carcinosarcoma from pure sarcoma. Many statements he has given. These two I could read that. And can you tell that how to differentiate sarcomatid carcinoma and carcinosarcoma from pure sarcoma of bladder?
It depends upon how you sample the. There is no correct answer for this, because how you sample it. Like in our case, I showed you, there was no urothelial component. Only neuroendocrine component and sarcomatoid component was there. There was no urothelial component in our case. So it depends upon how you sample it. Have you sampled the entire specimen, and what are you finding? What are you finding in the thing, and which component is more aggressive? Like in this sarcoma and neuroendocrine, I think neuroendocrine will be more aggressive in this. And as I told you, in sarcoma also, there we can find what is the component. Is it just a simple spindle cell pattern is there, or any towards pleomorphism it is going? Pleomorphic sarcoma or rhabdomyosarcoma, osteosarcoma, whatever it is. So depending on the component, and it is in its grade, and then the percentage of that tumor we have to call accordingly.
Percentage is important, yes.
Important, yes. So that is why proper grossing of the specimen is important.
Dr. Asranti, I just will take a second to congratulate Dr. Vishal Rao for this excellent talk.
Thank you, sir.
And it's been very educative. And Dr. Sudha Murthy for being a wonderful chairperson. Both of them, I think, they've covered most of the things. It was very educative and informative for all of us. Thank you so much.
Congratulations. Congratulations to Dr. Vishal. He has done an excellent job with the, address the basics. Along with that, you also address the issues, the problems the usually faced in day-to-day practice.
Yes.
That was very good.
Yes.
It was good. Thank you. Kim, madam.
how frequently do you see oat cell carcinomas in the bladder?
Madam?
Oat cell carcinomas.
No.
Or small cell carcinomas.
Very rare. No, video I have not seen.
Yeah, I think the important point when you are calling neuroendocrine tumor differentiation is to differentiate from the small cell carcinomas, because neuroendocrine definitely is going to have better prognosis and better behavior than the small cell carcinomas. I think that should come up in the differential diagnosis. And one has to try and differentiate between the two, because the small cell carcinomas, as usual, is going to have very high mitosis, and neuroendocrine carcinomas relatively would be less benign compared to small cell carcinomas. I think that we have to keep at the back of our mind, because small cell carcinomas also can show areas, very similar to a neuroendocrine tumor. I think we do see off and on small cell carcinomas, maybe that, we have such a huge, big, one of the best center of urology in PGI. They are very active. Many surgeons are there. So we get a lot of resected specimens of bladder tumors. Maybe because of that, we do see off and on. So I think that has to be kept at the back of mind, because patient is going to survive in months only.
Yeah.
So I think it's a very important differential diagnosis.
Yes. So we'll wind up the meeting, madam.
Yes.
So thank you, Dr.
Definitely.
Thank you, Dr. Sudha.
Thank you everyone for attending it. Yeah, thank you very much.
Everyone for
Thank you.
attending. So many has attended.
Vishal, let me just tell you, as a senior person, you seem to be having so much of material, but your publications are very less. Push your publication.
That's a good
So-
suggestion. Thank you, ma'am.
Yes, madam. Yes, yes. Very nice. Very nice.
We have only one journal, ma'am. IAPM.
No, work harder, molecular, you can publish in better journals.
Yes.
Absolutely.
Good.
Editor of that book, Blue Book.
So thank you all. Thank you all. We'll finish wind up.
And those are by contact, those blue books, invitation by contact only. Don't pay much attention to that. Every year, the different the classification is going to change.
Yes.
Don't pay attention to
Yeah.
Take your own impact.
There are some more comments, Dr. Vishal. Can you please take it on a private this thing? We will close the meeting. Thank you so much.
Yeah. We'll close.
Thank you very much.
Thank you.
Everybody for attending. Yeah, so Ashanti, thank you very much.
Thank
Yes,
you.
madam. Thank you.
Thank you.